Yes, hello everyone, and welcome to another session of our inner circle. Am I audible to all?
Yes, sir.
Yes, sir.
Anyone who is attending this for the first time?
Myself, sir.
Myself, Dr. Atandapuri, I am also attending for the first time. So,
Sorry, Dr. Artin.
myself, yes, sir.
Yes, hello, madam. Hi. I think you put
Yes,
up a case also, which we can discuss if things are going fine.
yes, sir. Sure, sir.
Right, right. Just put on the AC or something here. Anyone else attending for the first time?
Myself, Dr. Mallikarjun from Karnataka, sir.
Hello, Dr. Mallikarjun from Karnataka. You also for the first time.
Yes, sir. I met you in the Bangalore, sir, in global conference.
Great, 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 great. So nice, so nice. Perfect.
Recording in progress.
Perfect. Sounds good. Is there anyone else who is attending for the first time? I think you people are the lucky ones because on a very short notice, we put up this inner circle. I had some free time and I thought whoever wants to take this advantage opportunity to share your doubts personally, I can, discuss and share the doubts personally with you all. So just
Thank
I
you.
think it's going to be a very limited edition inner circle today. Typically, we have close to 100 people or more always, but I'm not expecting more people because of the short notice period given to all. I'm sure everyone must be busy on the Monday, and that's how even I like, but however, to wind up my days early. So typically by this time I'm free on most of the days. So I thought sometime I can give because I see a lot of queries coming up. So let us, without wasting any further time, I think what we can do is, since it's a very limited to few people, we can directly interact. I can allow people to just raise your hand and ask the query. So is it possible, Savita, we can start making co-host to whoever is asking the query? Or you can, what you can do is you can put up, I think it will be easier and more easy if you can just put up in our WhatsApp group, the inner circle WhatsApp group. I'm reading it. And if you can just put up your query over there, I can take it one by one. So just start shooting your
Yes,
queries and I
right,
can definitely start taking them up one by one.
right, sir.
So I'm waiting for your any of the queries which you are having and we can put it up and start discussing.
So, can I start?
Yeah, yeah, please,
Yeah.
please.
So you remember the case in the morning we were discussing that cleft
Yes.
palate and lip case,
Right.
and
So
I'm
let
going
me
to
just
share.
share that case with everyone so that everyone is in sync. So I'll have to just figure out. Yeah, yeah. So Artinder madam, great. So you have already put up this case in the group as you see on the OPG. Now, whether the patient has cleft lip, cleft palate, or any medical problems, that is slightly, I can say, irrelevant to us while planning. What we need is the sound dense cortical bone. So as we see from your case, if I'm not mistaken, this OPG is not very clear. You have the nasal cortical except for the anterior nasal spine, which looks to be missing. Am I correct, madam?
So the nasocortical bone in the, on the right upper region, it seems like there is a fissure. I'll share a close-up of this X-ray. I have taken a picture, a little close-up where I planned it.
Yeah.
I'll share in the group.
And are you going to
So,
remove the anterior teeth by any chance?
yes, sir. Yes, sir. I'm going to plan because there are deciduous tooth. If everyone can see that, there are deciduous teeth. So you are saying these are zygomatic implants?
Zygomatic, or you can even go for frontonasal in such cases. What your plan looks absolutely correct. You can
Yes,
see
sir.
if you're not extracting till 4 or 5, because right side, I think you have only the first molar. I hope everyone is referring to the OPG X-ray over here, right? So on the right side, you have only, on the right side, you have going till second premolar. So placing the
So we have
second, sorry,
we have in the second quadrant the incisors, deciduous incisors.
correct.
Yeah. So we have A and B in the second quadrant. We have D in the first quadrant,
Correct.
Other than that, we have three permanent teeth which are palatally impacted. Like we can see from the palatal side, all these teeth, like because of the.
Madam, how much of an experience you are having with this kind of complicated surgeries?
So I have done a case with cleft lip, but with the cleft
So
palate, I am
if you're
like.
worried, what I would suggest you do a staged approach wherein you extract the teeth which need to be extracted, including the impacted teeth.
I'm planning all to extract, sir, from deciduous molar till that lateral incisor on the second quadrant. I'm planning to remove all of them. And as I shared, the six implants, I am worried for the implant which is exactly looking close to the nasopalatine, that fissure, that cleft.
Correct.
Yeah. So
That
the
is not a
plan.
problem as long as even if there is a fissure, if you have a PCS implant, which is
Yes, sir.
a wide body implant, it will engage the buccal lingual as well as those areas of fissure and you will get a good torque.
But as you were asking that that nasocortical bone is available or not, I didn't get it. Like where exactly we are
Yeah,
talking
so
about.
let me just put up my screen and now show it to you what I am primarily planning to do. So just let me put up the white screen. Now, is everyone able to see has everyone seen the X-ray which we are discussing? I hope everyone is seeing the X-ray which we are discussing. So what we need to look out for, so let's say you have a situation where all this bone is also resolved. Let it be any case. What you need to look out for is the nasal cortical over here. As long as the nasal cortical is existing, you can engage the implants through a cyst, through a fissure into this nasal cortical area. So that's the crux of the entire conversation. And on the right side of this case, as you see, the second premolar is missing. You are
Yes.
able to extract. You can even think about placing a zygomatic implant if needed. In the fissure area, you can place a wide body. So just I want to know, which your X-ray is not clear, if the nasal cortical is present, it shouldn't be a problem at all.
So I am not trained for the zygomatic implant.
Exactly what I was telling you, madam. So what my
Yes.
suggestion to you would be to
Yes, sir.
remove all the impacted teeth.
Sir.
See, it's very easy to put on a drawing board and show you things. But I
Sir.
think from your case, from practice management point of view also, and from the patient success point of view also, extract
Sure.
all the impacted teeth, give a RPD denture, let things heal up, make a CBCT X-ray, share the CBCT X-ray in the group again. We will check for areas where you can engage.
Okay.
And
So
then
is
once you have defined the areas where to engage, either you do it yourself or take help of any expert and do it. Doing things together is no issue, but it also depends upon the skill level.
So I told you before also, I have placed like only 500 plus implants till now.
Yeah.
So basals, and I have treated a very thin ridge cases also, but I am not trained in zygomatic implants for sure.
That is okay, madam. If what plan you have given, if you feel that you're going to get good torque, is
Yes.
absolutely no problem. In such cases,
Yes.
I strongly recommend if you're not sure, also you can create a bar. And because the patient may probably, from what you're saying, cleft lip, cleft palate may also have the missing flange areas and all those things. So
Yes.
sometimes, in fact, always we think about fixed, but in such
Sure.
cases, when you place implants, create a bar and create a click-on denture on it. Sometimes you may get much more superior aesthetic results than even a fixed prosthesis.
Yes, sir.
Simply
So,
because of
so
the flange.
this patient have a acrylic plate for the palate region. He's already wearing it,
Exactly.
and yeah, and he
So
got
if that is
operated.
the case, then by default, even if you have one or two less implants, it will be implant plus ridge supported prosthesis, which is called a type C prosthesis. So
Okay,
you will
sir.
get some retention from the denture acrylic plate from the adjacent teeth. Also, you can create support and also from the flange area. So these are not textbook solutions, but definitely case specific solutions you can decide and
You're
whether
right.
and
Can
areas
we?
of implant where to place and all remains same irrespective of the case for all of us.
Correct. Correct, sir. So one more thing I want to know, if the patient want Emax crowns for his implants, the Emax crown, can this ridge, that acrylic plate can fuse with this Emax crowns, that which we are thinking to cover the palate region?
Mm-hmm.
Is it
Yeah, so
possible to
you can
connect?
what if you wish to, you can upgrade it in the future. Wherein initially, as in the upcoming prosthetic book, I have put up a case where
Sir.
the frame is a polomolo type of bridge, And then initially you can have acrylic, and later on you can remove the acrylic and replace it with Emax or zirconia crown. So just I think with the right now you don't plan so much for the prosthetics. Right now you just plan to place the implants, get a flange over there, and in the future date, especially if it's an overdenture, changing the prosthesis shouldn't be much of a problem.
Okay, so you are saying we should give a temporary crowns for now?
For me, with this conversation, my conclusion to the conversation is extract the teeth. If
Right,
you're
sir.
confident, you place the implant simultaneously. If you're
Sir.
not confident, you place a RPD, take a
Okay.
repeat CBCT after a few months, and then
Right.
enter after discussion. If you're confident and you get sufficient number of implants
Yeah.
with good torque, then you can
Yeah.
make a FPD
Okay.
with a dual framework design, which is mentioned in the prosthetic board. And later on, without removing the frame, you can only remove the crown. So it's basically like a polymer. Let me put up the.
So can you share?
Sorry.
I don't. Can you share that
Yeah,
appliance?
let me just try to put up 1 second. Let me just see. I'll tell you right away.
Sir.
Okay. So I hope everyone is able to see the whiteboard again.
Sir.
Let me just share the whiteboard. Are you able to see the whiteboard again?
Yes, sir.
So let's say you have placed the implants. So right now we assume that your implants are placed. Now you have a frame, okay, which is like this, and you have a milled. So this frame is milled like this.
Okay.
Made of titanium or cobalt chromium. I would prefer titanium. On top of it, your crowns, your acrylic crowns, your PMMA crowns are sitting like this.
Okay.
Cemented.
Okay. Okay.
At a later date, you just remove the acrylic crowns and then switch to the PFM or zirconia or whatever you are. So you're not removing the frame, you're only changing the crown. This is called a dual frame, and extensive discussion of this is mentioned in the upcoming book.
Right, sir. Right.
So let me just help other people also. I hope Dr. Artinder, it was helpful for you.
Very much.
Dr. Bal Mani Kandan Srinivas, I'm sorry if I've not got the name right, has asked, sir, some patients are not willing for rehabilitation of basal implants immediately after extraction. They are coming after 5 to 10 days and asking for implants. Excellent question. In these cases, can we place the implants or have to wait for 3 or 4 months? Excellent question. So for this, what we need to understand is that bone is not aware about us or the patient. So the moment we extract, the first thing which starts after 2 or 3 days is the osteolytic activity. So this osteolytic activity, the osteoclasts start dissolving the bone, which continue for roughly, which accelerate by 2nd or 3rd week, which is around 15 days. After that, a soft bone formation begins. That is called the Vaughan bone. So this soft bone, which we call the Vaughan bone or the matrix, is laid up to 45 to 50 days. And then it starts mineralizing and getting calcified, which means that the weakest part of the bone or the bone mineralization is the 15 to 45 day, which is the Vaughan bone. So let's say that the patient has got an extraction done and it is 3 days after the extraction. Now you have roughly 12 days to start your work and finish the work. So if you feel, let's say patient has done the extraction, second what point you need to consider is when the extraction was done, do you have good sound bone to engage? So let's say patient has done the extraction of central incisor and you're planning in that case a BCS implant where you're going to engage the nasal cortical and it is unaffected by the previous surgery, you can take a chance. In such situations, what I've observed is that a single implant is more risky than a splinted case, which means that let's say the patient has extracted 3 or 4 teeth and now you're going to place 3 or 4 BCS engaging the nasal cortical and you're going to start the surgery on 4th or 5th day. You need to first primarily curate very nicely because you will see a lot of granulation tissue, soft bone, unmatured bone. You need to remove all of that without it getting trapped in your implants. So if you feel that you're able to curate out everything nicely, you are able to splint nicely, and if you're able to complete the case within 10 to 12 days of the extraction, which means, let's say if I've got the extraction done 5 days back, so I have now 7 days to complete my job. And those extractions were not very challenging or very traumatic, which means that they were not very firm teeth. Let's say they were grade 2, grade 3 mobile teeth, where the cancellous bone is more involved rather than the deeper portions of the bone. I will go and do it. This is from the practice management point of view. I will not make the patient wait for 3 or 4 months and lose the patient. So this is how we apply the science to the practical part of it. I hope Dr. Balamani, you got your answer on this. Second question is, what about placing implants in relation to a tooth having canine space or buccal space infection? Do I have to wait? So again, now when it comes to infection, let me pull up the whiteboard again and explain you why the BCS. So let's say that you have a situation like this, where you have an infection over here. Okay, and you are removing this tooth. So you removed this tooth and now only the cortical margin remains. Now think over it and answer. So we have curated all this infection. So you removed all the infection and now you have an extraction socket. Tell me, think about this and tell me, if I place a bullet shape implant, a conventional implant, it will not permit the drainage of infection through this area because the bullet shape implant is blocking the pathway of exudate. I know this is getting a bit scientific and boring, but if you place a BCS implant which is away from the site of infection, this will in fact promote the exudate, the pathway of the exudate to the purulent exudate to discharge, which means that even in an infected socket, you can say a cyst or those kind of sockets also, the moment you have curated and you place a deep implant, a BCS implant, which is deeper than the site of infection into the cortical bone, the shaft of the BCS implants actually promotes the exudation of the, promotes the pathway of exudation. It allows the purulent discharge to get out rather than push it in with a bullet shape implant. So this is the primary difference why a BCS implant, a smooth surface implant, is more relevant to us than a conventional implant. How many of you found this thing something new and you haven't heard it before? How many of you found this new? I just want to know that a BCS implant, actually the design of the implant promotes the purulent exudate to get discharged, as opposed to a conventional implant. When you place in an infected socket, will not allow the pathways, the exudate pathways, they will block it. How many of you found this new? Just type new in the comment box. And I hope you're able to correlate with what we are saying and enjoying this new findings or new learnings which you're getting. How many of you found this new? Great. Dr. Sumit, Dr. MD Spo, Dr. Muhammad Ali, thank you. Okay. Right. So if there are any new questions, if there are any more questions please put it up so that I can answer it to all of you. So this session is a direct interaction. I'm not prepared anything. Whatever your queries are, you can just put it up and we will take them up and we will try to help you out.
Sir, I'm definitely going to have that prosthetic book because my concern, I'm very much impressed with basal technology. That's why I am practicing only and only basals. But the prosthesis thing, like immediate extraction implantation, like we do extraction and we put an implant, the healing is amazing around the smooth surface. But when the prosthesis comes, within that 2 days, the gums again recede a little. And that gap comes and that hurts. So if something you can suggest for that.
So for this, is it possible that, I'll just see if I can pull out a whiteboard. Rakhi, whiteboard mil sakta hai by any chance? It's a very nice question again. And I think this is all actually, I'm not sure if such an advanced level of discussion should happen, because I see a lot of new people. How many of you feel that we can do such advanced level of discussions, because there are a lot of people who are still actually getting well versed with what is BCS KOS. This is a very relevant question, Dr. Artinder. But I think
So it hurts because that's why I just thought to put
let
up
me
this
see. Let
question.
me take a consensus if people want such. Otherwise, only we both are talking, and then others are just wondering what is happening. I don't want that.
Definitely, definitely, definitely.
Okay, okay. So I think everyone.
People are saying yes.
Okay, quickly I'll take up this question for all those who are interested. So till my team is setting up the board for all of us. So the question from Dr. Artinder, and this is the last question permitted to you, madam. Let others also take advantage of this session. Okay, but we'll take it up for the benefit of all. So what madam's question is that a lot of times in an extraction socket, you find that you have placed an implant, and by the time the prosthesis comes, the tissues have shrunk. Now, what I'm explaining to you is a very advanced technique in which you want to complete the work only in one session, which means you're not planning for any kind of temporization. I mean, the simplest way, the ideal way is for anyone to plan a temporization and then go ahead and make the permanent. I hope everyone agrees with this. So the simplest way to counter tissue shrinkage is to plan a temporization. Temporization can be done with 4 different techniques, which are mentioned in the textbook, and then switch to permanent. I hope everyone agrees with this. What we are discussing right now is if you don't want to do temporization and still want to place a crown and counter that tissue shrinkage which is going to happen. I hope everyone is able to understand the discussion. Yes or no? Please let me know that much at least.
Yes, sir.
Perfect, perfect, perfect. Okay. So just one of you please come here and shoot me. I'll just mute this. Yes, just see. Am I audible to all?
So you
Am I
are
audible clearly?
yes,
Yes,
sir.
sir.
Is it clear now? Everyone
Yes.
just put up in the chat box because now I'm able to read only the chat box. So am I audible clearly, everyone? So what happens typically is that whenever there is this kind of bone morphology and we want to extract and place an implant, what will happen after a few days? You will see the tissue is shrinking. Am I correct? Is everyone able to see this board? So are you able to showing the board clearly? Right? Okay. What we should do is first thing you should do is a subtractive. So what we normally do, let's say when you're doing a conventional implant and you have such kind of a situation, okay, what we have been taught is you place your implant and you put a bone graft material and you put a membrane, and that will prevent the tissue shrinkage and you will get a good profile. So this is called as a additive surgery. This is called as a additive surgery. Instead of doing a additive surgery, what you should do in such cases is what we call as a subtractive surgery. So whatever the area, so you is prone to tissue shrinkage, you just open it up a bit more with your bone ronger, you trim it. And now you place the implant just 1 millimeter deep and you place your prosthesis, you will see the beautiful prosthesis emerging and there will not be any tissue shrinkage. The example of this has been also mentioned extensively in the first book. So anyone who has gone through the the first book, you will see that there is an example of a gummy smile case with a 4-year follow-up where the extraction, removal of gummy smile, and all these things was done simultaneously with a 3.5-year follow-up and zero tissue shrinkage. So this is what we call as bone and tissue manipulation. This entire technique more in detail is also there in the HD video library. So those of you who have the HD video library, I request you all to just go through this video of how exactly to do the tissue manipulation so that there is absolutely minimal or zero shrinkage and you can manage the case without this kind of problem. So I hope whatever little bit I could share, I made sense to all of you. And I thank Artinder madam for asking this question.
Thank you, sir. Thank you. So you are saying 1 mm bone we can, trim with the bone ronger. We can.
Yes, yes, yes.
Yeah.
So you
Okay.
can.
So you are mute. Your mic is mute. So you are not audible.
Am I audible now?
Yes, sir. Now
Yeah.
you are audible.
So yes, you
Yes.
have to trim the bone, but there are techniques to trimming, how much to trim, where to trim. So that is there in the HD video library. Now, those of you who have missed the HD video library and the book combo, a lot of people have requested me. So once again, only for today. So the combination price is around close to 25,000. But those of you who want the HD video library with the book, the same offer price like last time, 16,000 rupees is what we can give away for today. So I request madam and anyone else interested in such techniques, you should go through the combo HD video library and the reading material which is there in the book. So let me take up more questions, please, so that we do justice to all those who have attended today. So just let me pull out. Yes. So Dr. Mohammed is asking, can we place compressive implant in periapical pathology cases? Yes, you can place. Only thing is that place you should curate very nicely, and the place you should be technically placing the implants in good sound, healthy bone. You cannot place it when a granulation tissue is present. Otherwise, it will be very painful, not only after the placement, but even during the placement. So definitely there is no contraindication, but you should be able to curate it. And if good bone is existing and you are able to curate everything, you can place it after good curettage. So Dr. Malika Arjun Kumar is asking, sir, please explain the rule of 6 in pterygoid implants. Dr. Malik, I am really sorry, but I'll have to skip this question. It's a very good question, but it will require almost an hour to answer this because there's a good sequence to this. But for this, what I can do is I can share you the YouTube link of my webinar in the Bangalore conference, wherein I've explained this thing in detail. So those of you who have missed it and those of you who are not subscribed to my YouTube channel, I think this is a good time to subscribe to my YouTube channel and go through this video. Let me just pull out, sir, this video for you and put it up. Just give me a minute, please.
Okay, sir.
It's a good 1 hour lecture, and in that I've explained this rule of 6. So just give me a minute. Savita, can you pull out this Bangalore workshop?
You didn't complete that in Bangalore, sir.
So whatever time I was given, I spoke, sir.
You were about to complete it, but you didn't get the time, sir.
Right, sir. Right. Happens. No problem. We'll do it some other time where we can keep it exclusively for the inner circle people and discuss it. I hope you enjoyed whatever you could hear in the conference, but
yes, sir.
Right. Okay. But let's see how I'll keep this question in mind, and maybe I can make some video or something, and definitely we'll try to answer you, sir. Don't worry.
Yes, sir. Right? Thank you.
So meanwhile, Savita, for those who want to go through my lecture on pterygoid implant, Savita is putting up the YouTube link. So all of you can just go through it and let me know your views on it later on. Dr. Faisal is asking, if someone is new to implantology, is it necessary to start with conventional and then shift to basal, or new directly to start with basal? Again, it's a very interesting question. Now, is there anyone in this group who has directly started basal implants, not done any conventional implant? Is there anyone in this group who has done that?
Sir.
Artinder, madam. So, madam, you are the right person to answer it. What you feel? So, if someone has skipped and not done any conventional implants and they want to directly start, let me first give my view.
We are the fresh people. We have fresh life.
One thing is, remember this one rule. So, Dr. Faisal, are you there online by chance? Dr. Faisal Sheikh, right? Am I correct?
Yes, doctor, I am there online.
Yeah, Dr. Faisal. If, for example, do you have kids, Dr. Faisal?
Kids?
Do you have kids?
Yeah, I have one daughter.
Son, daughter, son?
Yeah, daughter.
Daughter. Now, let's say your daughter wants to learn cricket and she starts practicing with leather cricket, leather ball. Okay,
Okay.
so you enroll her in a coaching, she will wear the pads, the coach is there, they take good safety precautions, she learns properly, and she starts playing leather ball cricket.
Okay.
Will she be able to then play with a tennis ball or a plastic ball?
Yeah, sure, she can play. Once she starts with leather, she can play.
Right. So for me, if you look at the basal implants, it is a leather ball game. Why I say like this is, sir, because you are handling resorb jaws, you are handling challenging cases, and you are loading immediately. So those of you who want to directly come to what we say a new age solution, because according to me, if you ask me, bone grafting is outdated. If you ask me, I mean, for all those who are still thinking about IPRF and APRF and all those things, I sincerely believe it's all outdated. No patient is going to allow you to suck the blood out of his hand and do all those stuff. So that's totally outdated. Immediate load solution. If you go to international conferences, discuss anything with the international doctors, everything is about immediate loading. So those of you who want to directly upgrade now, how many of you think that if we skip a mirror amalgam filling and directly learn a composite filling, things should work for us? I think most of us. I will not be surprised if after 5 or 10 years, people don't know how to make an alginate impression, but they know how to scan very well. So that's how things keep moving ahead. So I don't see it as a problem. But of course, if you do a conventional implant in simple bone cases, then take it slow. There is nothing wrong in it. But in my journey where I've trained so many doctors, 10, 12 years, I have come across lots and many of the doctors who are directly started with immediate basal implants and never gone back to think about anything else. So that's my thing. But Dr. Artinder, considering you're already one of them, please give your quick views on this question to everyone.
Yes, so I think basals are an amazing entry. We have the person who want to do first know about implants, no, so basal is the best thing because no wait for the patient, no wait for the doctor. Good engagement, good results. I have seen 4 years of results. I have seen no failure till date, but I have seen floating conventional implant somewhere in the maxillary sinus.
Okay.
So, yeah. So I believe this technology is totally different from conventional. The science is totally different. But for a person who learned conventional, for them it will be a task to learn basals. But for a fresh mind, definitely yes.
Right. Sometimes it is difficult to unlearn and relearn actually.
Yeah, that is difficult to learn a new thing and just keep it to you. It's amazing, but for conventional people, it will be a task. But yeah, if they start accepting it, it will be easy.
Thank you, madam. Thank you for sharing. So we have put up the YouTube link on the pterygoid lecture with the tips and tricks. So those of you who want to know more about pterygoid, please go through that link. So Dr. Varun, before Dr. Varun's question, there is one more question. So Dr. Ajit is asking Mr. Jerome OPG, sir, can I save the good teeth in this case and connect to the implants? Yes, absolutely you can do that. Now let me give you 3 or 4 good tips. Whenever you are connecting the implant to a natural tooth, wherever possible, the tooth should be mesial in the construction. So if you're making a construction where you're placing a pterygoid or an implant below the sinus and connecting into the 4 and 5, that is your best way to move ahead. So wherever possible, the implant should be mesial in the construction. Whichever tooth you are connecting to should have a minimum 5-year survival rate. Minimum 5-year survival rate. RC treated tooth, post and core treated tooth should be eliminated, which means it's better you extract and place an implant there also rather than connecting with those teeth. And the kind of connection should be a rigid connection. It should not be you don't need any kind of stress breakers or anything like that. If you're doing that, I think in my practice, in so many years, we always prefer to connect wherever possible implant with tooth. And I can tell you from my experience that the prognosis is almost, if you have followed these 4 rules, the prognosis of the case is almost 100%. So that is how it is. And you should, wherever possible, connect the implant with the tooth. Now, Dr. Varun is asking how to access the quality of cortical bone? I'm not able to understand. Dr. Varun, are you there online? If you can just unmute yourself, Dr. Varun, and let me know. Can we unmute Dr. Varun and let him ask his question? Varun Bhatia, yeah. So Dr. Varun, are you there online? Please join us and let me know your question again. Yes, Varun, we are trying to unmute you. Just give me a minute. Meanwhile, let me take up Dr. Vinay's question, sir. Connecting implant with tooth, will the biomechanics work? That is what I'm telling. They work 100% well. From my experience, cases I've put up in the textbook also, and from my 14 years of practice, I can assure you that whenever you do that, you will have very good prognosis with immediate load implants.
Yeah. Hello, Dr. Rohan.
Yeah. Hi, Dr. Varun. Nice to see you. Yeah.
Yeah. I just want to know how to access the quality of the particular cortical bone. For example, if I am putting in a 1-2 area, if I feel that cortical bone is soft and I have to shift little bit mesial or distal. So before shifting, or how to access pre-hand in the OPG, or how to access it, this particular cortical bone is correct for me.
This is very, very nice question. Thank you once again, Dr. Varun, for asking this question. For this, all of you, I want you to just give me a second. Let me put up 2 OPGs for you. And let us focus, for the sake of discussion, on the nasal cortical bone. So I put up, it's okay if you are wrong also, but I want all of you to answer this and, just see on the X-ray right now, which I put up, and let me, you just share your view as per you, this nasal cortical. And if you compare the case with the previous case, which we discussed, so one of the simplest technique is to just look at the density of the bone with the naked eye. And now you look at these 2 OPGs which I have just put up right now. And as per most of you, is the OPG 1 having the more dense nasal cortical or the second one? 1 or 2? Just quickly you can answer 1 or 2. Is the OPG number 1 having more dense cortical or the second one?
Doc, the OPG is not visible in the present.
Sir, you have to refer in the inner circle WhatsApp group, sir. Okay. So Dr. Chetan Dedia is saying 1. So I think everyone is saying 1. So Dr. Varun, so one technique of knowing beforehand is to, with the visual examination, you think whether it is dense or no. The second technique is, in fact, the almost like a confirmatory technique, is that when you drill, please, all of you listen to this carefully. You try to make out whether this is hard bone or dense bone. Don't think about D1, D2, D3, D4. Think about hard bone or dense bone. Let's say for some reason, you missed out the density or the quality of the drop or the quality of the cortical. 2 things you can do. One is you can use the bone expansion screw. I hope you know what is the bone expansion screw, and that is why attending all the inner circle sessions is important, because now you can connect the dots and you can place it in your osteotomy. 2 things will happen. When you place the bone expansion screw in your osteotomy, let's say the bone expansion screw is spinning, it is soft, it is moving, which means you can assume that your cortical bone or the cancellous bone is soft in nature. Let's say it is very difficult in going in, that means the quality of bone is good. Let's say you're still not sure what to do. It is better you pick up a wider diameter. So if I'm confused whether I should pick up a 3.5 or a 4.5 diameter implant, I will pick up a 4.5 diameter implant. The reason I will tell you, if I pick up a 3.5 diameter implant and try to place it in the cortical bone, you may reach the opposing cortical, but you will not be happy with the torque you achieve. But if you pick up a 4.5 implant and you place it in the cortical bone and it is dense, which means you made a mistake. Instead of soft bone, it was hard bone, but by mistake you placed a wider, it will get stuck up. You will always have the opportunity to come back, either go with a 3.5 implant or drill more. So we should know the mistakes we can make to keep our life simple. So the simplest way to assume the quality of bone when you don't know the quality of bone is assume it is soft. How many of you found this as a value tip? Just let me know. Are you able to understand the thought process? In general, in the sinus area, maxillary sinus area, always, and in the premolar area also, sometimes you will see the sinus cortical, always diameter 5.5. Just remember it as a rule. Don't even ask anyone which implant to use. Always diameter 5.5. That's the softest bone. In the nasal cortical area, if the height and width is good, always QoS implant. Don't even think about a long BCS 26-29 implant. If you're engaging the nasal cortical and you're in doubt, then assume it's a soft bone. I hope Dr. Varun, you got your answer and it was satisfactory. Yes. So let me take up the next question. Doctor, I hope I'm not missing any question. Let me just see. Dr. Sheikh is asking, sir, in the nerve bypass case, how do you decide the angulation of osteotomy like buccal to lingual or opposite direction with respect to OPG? Amazing question, Dr. Sheikh. Thank you for asking this. How many of you want to know the simplest way of knowing whether it is a need for a buccal bypass or lingual bypass? Type me in the comment box. One of the simplest way. Now, friends, what I'm telling you, please understand, is from my years of experience into implantology. Almost every day I'm placing implants, and mind you, I'm a radiologist, which means that I have the knowledge, extensive knowledge of interpreting thousands of CBCT. And in our college days, on one particular day, we used to probably interpret maybe 50, 70 odd CBCTs. So you can understand the workload we were having. So with that knowledge and my knowledge of doing surgeries daily, I can assure you this, what I'm telling you. So just focus on the whiteboard. Okay. Whenever there is, let me just put up the whiteboard once. Are you all able to see the whiteboard?
Yes, sir.
Yeah, once. Yeah. So whenever there is a undercut is present, you don't even have to look at the OPG. So whenever there is an undercut present, is there a mandible over here? Please give me a mandible, lower jaw. Whenever there is an undercut present, without even thinking, so the only examination I do when the patient comes into my chamber is I ask the patient to open the mouth. When the patient opens the mouth, I feel the undercut. See, nasal, let's assume it's a full mouth case. Unless it's like a cleft lip, cleft palate case. Nasal cortical is always going to be there. Pterygoids is always going to be there. It's as simple as that. Only thing we need to make a decision whether a zygomatic is needed or you can manage with the small implants below the sinus. That's the only decision you need to take. In the lower jaw, anterior mandible, you're always going to get the implants. So technically, the only reason you need an X-ray is to see whether you, with the position of the nerve and the height of and all those things. Whenever there is an undercut present, like this, okay? Whenever there is an undercut present, so just when the patient comes, ask him to open the mouth and feel the jaw of the patient, lower jaw. If the undercut is present, it's a lingual cortical engagement. As simple as that. Forget textbook now. How many of you want to start doing practical work or you want to get stuck up interpreting CBCTs and doing complicated stuff? I am telling you one value add tip from my years of experience. Undercut present, lingual cortical engagement. Undercut not present, buccal cortical engagement. So for this reason, let's say that this is situation A, and let's take another situation. This is situation B. Okay. And first one, this one is situation A and this is situation B or 2. In which case are you going to do, after understanding what I just mentioned, in which case are you going to do lingual and in which case are you going to do buccal? Quickly in the comment box. In which case are you going to do lingual cortical engagement and in which case we are going to do buccal cortical engagement?
So one is like lingual cortical.
Perfect, perfect. And that's how it is. If you look at the resorption of bone also, the mandible expands by centrifugal resorption. Everyone knows that the mandible, it will expand, it will become bigger as it resorbs. So the mandible, there will be the bone will keep resorbing over here, will keep resorbing here and depositing on the buccal aspect. This is the buccal. This is the buccal aspect. This is the lingual aspect. So as the bone keeps resorbing more, that will become a buccal bypass case eventually. And when you have just extracted the teeth, there is no undercut. That's how the case you will have good height and bone, and you will end up placing a QoS implant. As the resorption begins, the undercut will start beginning. You will require a lingual cortical engagement, and as the resorption gets completed, you will end up with a buccal cortical engagement. How many of you understood the simplest way of deciding when to do a lingual and a buccal? I hope it was very clear. Just type super clear, please, because this is one of the simplest way to understand when to do what. Great, great. Right. So let me just take up one or two more questions as the time permits. Okay. But before I take up the next question, I wanted all of you to, just because it's more like an interaction between all of us, and this group is very valuable to me with the kind of community discussions we have. Would you want more of this kind of question answer sessions or a structured presentation by me? Just wanted to know, because I wanted to sync everyone together. So just wanted to know from this a quick review on the poll. A more structured session is what you people would like, or such kind of interaction, or it could be a mix of both. So maybe I'm thinking maybe, one or two structured sessions and then one or two, question answers. So amazing. Thank you. Thank you. I think all of you are agreeing to this. Okay. And let me just take up one or two more questions. Let's see more people we can help out. Thank you for the suggestion. Yeah. So Dr. Ajit is asking, sir, is it okay if the BCS perforates the sinus floor? Yes. You should perforate the sinus floor and engages the cortical. Yes, is absolutely okay. In fact, it is recommended and it is needed to perforate the floor of the sinus or any other opposing cortical when you are using a BCS implant. Dr. Vishal, okay, great, great. Is there any other questions which we can take up today? Anyone new in the group? Anyone is new to the group? So many people I'm seeing have just joined right now. I think everyone is done with the practice or they have a small break in between. Is there anyone who is new to this community? Just let me know, please. Anyone new in the community? I think there's no one new. All have been well. Okay. Hi, Dr. Anurag Basak. Nice to see you here. And Dr. Mohammed, please don't put up your questions in the chat box. You can just put it up in the WhatsApp group, please, because it will become difficult. I may end up missing the questions. So just luckily, I've seen one or two questions here. So I'm taking it up from the chat box. But I request all those who want to ask, put it up in the inner circle group. So Dr. Mohammed Adil is asking, is there any need to correct the anterior bone defect with the bone graft or any other graft? Absolutely no, sir. Yes and no. How? The only reason you may want to build a bone is purely from the aesthetic point of view. So let's assume a hypothetical situation. The patient has a very gummy smile, which means a high lip line, and the bone, because of the extraction, has resolved. And if the patient is very aesthetic conscious, only for aesthetic reason, you may have to bulk up the bone so that all the bone looks equal and symmetrical. For placement of implant, you don't require to place the bone grafting material in any case in basal implants, or for that matter in any situations demanding immediate loading. I hope, Dr. Mohammed, this is clear to you. Just type clear for me if it is clear. Hi, Dr. Sheikh. Nice to see you for the first time here. I hope Dr. Anurag and Dr. Sheikh, you're finding this enjoyable and fun. Dr. Girish is asking, sir, if we don't cement the temporary prosthesis in QoS, will it fail? The need for any single piece implant, let it be QoS or BCS, is rigid splinting. Now, when you use a temporary cement, there is always, so what you're doing basically is, instead of welding, you're using the prosthesis as something which is welding or splinting the implant. The problem with temporary cement is there is always a micro motion between the cement. Probably the cement can leach out, or if not, there could be a micro movement between your implant and the crown, leading to loss of splinting effect and ultimately micro motion of the implant. Micro motion of the implant more than 200 microns during the phase of healing. So let's say you have placed the implant, and for some reason, when the patient is chewing, there is a micro motion in the implant. If there is micro motion in the implant more than 200 microns during the phase of healing, is bound to fail. And that is why the recommendation is to use a permanent cement, so that there is no micro movement between the prosthesis and the implant. How many of you knew this? Please let me know. Just if you knew this or this was new to you. If it's new to you, just put up new. If you knew it, let me know that you already knew it. Great. So many new tips, aware of it. So 1+ CPH is aware of it. If you could put up your names, then it would be better, so I can, great. A lot of people knew, some did not, so I'm great. So a lot of people are not knowing about it, so now you know. So before I take up 1 or 2 more questions, I just wanted to update in the group that I was not actually expecting, but we are getting the record number of people who are joining us for the diploma program. And being the first program, we are going to limit the number of seats to 10 only. So those of you who want the detail, like how, we are correlating the theory with the practical. So someone of you who wants to know the in and out, I think the diploma program is for all of you. I will request Savita to join, to share the diploma program brochure. She's joining, she's just sharing it in the group. So it comprises of 5 modules. The first module is complete online module, wherein you will get a lot of online video material as well as reading material to go through. The second module is where you attend a 3-day workshop, where you will see me and the other mentors performing the surgeries and explaining you various techniques, tips and tricks via presentation, which will include immediate extraction, implants, intraoral welding, digital techniques, use of scanners, use of digital occlusal calibrations, and all those advanced techniques and tips and tricks, pterygoid implants, nerve bypass, and you will be placing them on the models as well. The module 3 of the diploma program, which is associated with the Romanian Institute, so you get an international diploma certificate. You will be placing the implants under mentor guidance. Now here the beauty of this program is that there are 2 options again. One is that those of you who don't have the patients or don't have the clinic can do the work with us, or those of you who have the patients in their clinic can keep the patient in their clinic, and one of the mentor will come down to their clinic to do the patients along with them. So, you can actually charge the patient around, even if you're doing a full mark, 1, 2, 3 lakh rupees, whatever you wish to, and recover almost your diploma fees. For the people who are registering for the first time, we are giving the material worth 1.5 lakhs free. So technically the diploma program becomes free for all of you. The fourth module includes the lab module, wherein you learn the simplest lab techniques along with the prosthetic techniques. And the fifth module, of course, is in Romania with the international mentors. So that's about the complete diploma program. And any one of you who is interested in knowing in and out about the diploma program, you can connect with Trisa Enterprise. I'm putting up the number, Trisa Enterprise number 93215 33493. So that's regarding the diploma program. Already the brochure has been put up. So, and as I told you, the number of seats are limited for the first batch, just 10 seats, along with around 1.5 lakh, if I'm not mistaken, of free goods, and the option of you doing your patient from your clinic under mentor guidance and recovering your fee. So those of you who are smart enough will understand that this entire program can actually become free for you if you just plan it out properly. So let me just take up the next questions. Dr. Raghuram is asking, can you make a small note on C finder? There are two C finders in the kit. So please note on. So yeah, that's a very good question. So they are both are the different diameters. So C finder is nothing but your scouting instrument. So just like in endo, you use a scouting instrument, hand file, and then a rotary file. Your C finder, as you have seen the video previously, is a scouting instrument. So the first one is around diameter 1.8 millimeter to be exact. It's written 2 on the C finder, but it's a 1.8 tapering to a 2 millimeter, and the other one is a 2.5. So in some cases it's not necessary what you are thinking as a C finder is only the pterygoid, but in lot of cases you also need to drill with a wider drill to get the opposing cortical. So you can use this as a hand instrument, like what Dr. Varun said. If there's any confusion in the density of bone, there's no harm in using a hand tap first and then your drills. So these are just two separate taps with different diameter depending upon in which situation you want to get the use of a 2 millimeter drill or a 2.5 millimeter drill with a hand tactile. So I hope this was clear for Dr. Raghuram. Yeah, just put up clear, please, so that I can start taking up the next question. So Dr. Maruti Dental is asking, in case of less interocclusal height. Super question. Superb question. Superb question. Let me answer this again. Now let's assume a situation. Is every one of you able to see the whiteboard? Let me just see if I can. So let's assume a situation where this is the maxilla and this is the mandible. Now, in such cases, if you don't plan properly, you will realize a lot of times that you have placed your implant correctly with good torque, but you don't have space interocclusally for a cement retained prosthesis. How many of you have encountered this situation? Just let me know in the comment box, please. Are you able to understand the situation? It's an excellent question where Dr. Raghuram has asked, Dr. Maruti Dental has asked that if you don't get interocclusal clearance, how to handle the situation. How many of you have encountered this situation? Right. So I think a lot of people have encountered Dr. Bala, Dr. Chetan. One of the simplest things to do in such a situation is to remove some bone. So when I start removing the bone, okay, so remove some bone from here and place the implant deeper. Place the implant deeper, and then you will have enough space to do your prosthetic work. Now, how many of you want to know one more super tip to understand how much bone to remove without actually having to open up the flap? How many of you want to know this tip, how I do it? This is special for all those people who took the effort to attend and are staying back till the end. You still keep getting all these value tips. which is going to make your work really. So what I do, let's say let's assume I'm operating a premolar area, and I've hit the nasal cortical at 14 millimeters or 17 millimeters, let's say. Instead of selecting a 17 millimeter implant, I will purposely select a 14 millimeter implant. Now what will happen is, when I place this implant head will submerge into the bone, because I have selected into the gingiva at least. Now I will take my SF11 burr or a electrocautery, whatever I like to use the burr, and just keep moving around the head of the implant till the head of the implant is exposed. How do I know if the entire head of the implant is exposed? I use the impression coping. If the impression coping fits up to the margin, that means the implant head is exposed. So this is how I like to guide myself how much bone to reduce by this simple technique. How many of you found this technique very, very simple? If you don't abide by, if you feel no, this is too much arbitrary, I don't want to, then the next way is to open up the flap, reduce the bone, make the measurement there. And there is one more thing you can do in such cases, is opt for a KOS or a BCS MU implant, which is a screw retained implant. So let's go back to that same situation where I don't have any space to do the prosthesis. I don't want to reduce much of bone. In this situation also, you can always place a screw retained KOS or a BCS MU implant and still get your prosthesis without having to remove any bone. So these are three different ways of handling this situation. How many of you found this super? Use of multi-unit implants, opening the flap, and without opening the flap. Three techniques to do the same work, depending upon whatever suits you. So technique number one, you open up the flap, you reduce the bone, then place your implant, and then the crown. Technique number two, select the implant of a lesser length. So let's say you're drilled till 17 mm, you purposely select a 14 mm implant and start screwing it till it reaches the cortical. You will see that the implant is submerged in the gingiva. Now all you need to do is take your burr, SF11 burr, and keep going round and round around the gingiva so that your implant is exposed, so that your crown can come on it. That's technique number two. I hope you got it, Dr. Adil. How many of you want more such techniques? I think you are most welcome in the diploma course, where you will get such fine tips and tricks which are not mentioned in any books. I think seeing the enthusiasm, maybe one or two questions, almost 1 hour. But let me just try and take up one or two more questions for all of you. So iPhone has asked, you guide us for cement retain and screw retain if there is less cement. Yeah, I've already answered this, so I'm skipping it. Okay, and I think all the questions are over, if I'm not mistaken. Is anyone in this group, wanting to give just a small feedback about today or any of the inner circle sessions? Just put up me in the inner circle group. Dr. Artinder, I will try to take up your question.
Yeah.
Yeah, but is there anyone who has attended inner circle sessions or just want to give a feedback on the inner circle sessions? What are your, things which you're learning? I just want to know, because for me, unless I understand what you are getting and what you want, I want to really structure it and frame it in a way where I can give away maximum to all of you. Can anyone just come online except Dr. Artinder, madam, if you may permit me to just take anyone else and just share a quick feedback of what you have probably gained if you've been attending the inner circle sessions. Are you able to connect the dots? Dr. Artinder, meanwhile, I'll take up your question. Do we need to treat the head of the implant before bonding Emax? You can use a metal primer if you want to be very specific, madam. If you want to be more specific, then you can even use a sandblaster to roughen the metal surface. But in my practical experience, I don't see the need to do it because of the very nice adhesive cements used nowadays. But of course, if you want to go textbook, then you can also place a rubber dam on your implants. So that
Sir, I just want to know, because I have done some cases where I placed without treating the head. I just wanted to know whether it will be a success. Recently I have done a case where I didn't treated the head of the
So
implant.
use a resin modified glass ionomer cement.
Yes, sir.
Don't
Yes,
use
sir.
a dual cure cement, and it should work fine.
So I have used Paracore dual cure cement.
It should work, madam. But if you want to be more specific, then what you could do is, as I told you, you could use a metal primer. If you want to, yeah. The problem is not with the metal or anything. The problem is at the Emax end, because Emax normally doesn't bond well with. So I think for Emax, what I have found from my experience is that the glass ionomer cements work well, especially when it comes to bonding with metal or adhering it with the metal.
So should I prefer then zirconia over Emax for bonding?
Anytime, but both work, madam. There is no problem as such. You won't have a problem.
Okay.
Right?
Thank you.
Yeah. Right. So I think with this, if every one of you can just quickly, put up your 3 key learnings for today, I want to know, because these sessions are totally unplanned. And I want to know from all of you, if really this 45 minutes, 1 hour, which I have spent, you have spent, was it worth for all of you? So if you could just put up 1, 2, 3 key learnings, whatever was your take home point. Thank you, Dr. OnePlus. Thank you for your feedback. Just curious to know, any one of you planning for the diploma course with us? 5 modules on my Romania trip and deeper insights with you, doing the lab work, patient hands-on under me, giving the exams and studying through the theory and practical. Any one of you who is planning to probably do the diploma course, just excited to know if there's anyone in this group. We already have a couple of bookings. I think we want to close it with 10 people this time. So Dr. Deepak, I will be very happy if you join us. We're keen to see you. And I really appreciate your enthusiasm. I think being such a senior doctor also, you're always attending all the inner circle classes. And yeah. So Dr. OnePlus, we are sorry we don't have your details. So if you could just share your name and your mobile number, it would be great. But thank you, Dr. Kalpana, madam. Thank you. Right. Dr. Nakul from Bangalore. Okay. Dr. Nakul, if you could just share your mobile number, we will definitely see and accommodate you if you are interested. Yeah. Thank you. Savita Raki, you can get in touch with Dr. Nakul, sir. Okay. Please put up his number. Yeah. Okay. Thank you, Dr. Fazil. And one practice management tip. Thank you. One practice management tip before I leave, because I think that's the crux of the entire thing. How many of you want to discuss a practice management tip before we all say bye? Or I think all of you are having patience and you want to wind up. Just let me know. How many of you have time for one practice management tip? Or maybe I would say a change of mindset rather, not a tip this time. Is there any practice management related question you want to ask? Then we can take that as a question. Is there any problem as far as your practice management is concerned? You can just shoot up a quick question. Hello, Dr. Lata from Bangalore. Yeah, we will get in touch with you. Any question related to practice management point of view? Or I can put up my own question and answer it. Right. How many of you feel in this group that your charges related to your treatment, let's say root canal, scaling, filling, it should be a uniform charge? How many of you feel that every dentist, for the patients who come in, the scaling charge should be fixed, root canal charge should be fixed, whatever charges you pay should be a fixed charge? How many of you feel fixed? How many of you feel flexible? Just want to put up in the comment box. Flexible or fixed? Fixed. So Dr. Mohammed is saying fixed. Dr. Swapnil is saying fixed. Dr. Subodh is saying fixed. iPhone is saying fixed. So Dr. Deepak has lost 3 FMR patients last month. They went to someone else for conventional, and I have been doing for ages. Yeah, this is also very nice. So you never tell the patient about basal, or even if now this is another tip I can quickly give you. Never never you tell the patient do basal or conventional. You always tell them that whether you're doing or no. Mind you, friends, take this as a valuable tip from me. Whether you're doing conventional or you're doing basal, or you're doing both, always offer the patient both the treatment plans and tell them you're doing both. So if I will do a sinus lift and place an implant, or I have this technique, I'll place 2 implants and do the crown. That's how we are speaking. If the patient asks you for an opinion, you give an opinion. If the patient has a preset opinion, like what happened with Deepak Nakra, for some reasons, he might have told about basal and patient wanted conventional, you will end up losing the patients. But when you tell the patient that we are expert in both the techniques, so we are not biased towards a particular technique. So if some particular doctor tells you don't do this, don't do that, he may be biased to only one technique, but we want the best out of you. The patient will appreciate you more, and he will tell you that, okay, I want to do probably, let's say I want to do a sinus lift and an implant, hypothetical situation. You can always involve your colleague and do the job. You will not lose the patient. But if you say, no, I will do only basal, I will do only this, then if the patient is not liked or connected with what you're saying, he may look out for a different solution. So how many of you feel that just by changing the way you are speaking to the patient or counseling, you may not end up losing the patients, like what has happened with Dr. Deepak? Do you agree with this, what I just mentioned? Right? So Dr. Deepak, I hope you don't lose any more patients. And let me come to this again, this question, how to convert FMR cases. Dr. Nakul, I wish you had asked me this when we all had more time, but maybe we can take up this question in some other time. There are lots of tips and tricks and techniques to speak to the patient, because what you speak matters the most. So let's assume, Dr. Nakul, and quickly before we answer, whatever I'm saying today, you are putting up questions and I'm answering. You're putting up questions. Will you remain in the session if you cannot connect with me? Dr. Nakul, this question is for you or anyone else who is getting involved. If you're asking me questions or someone else is asking me questions and my answers are not connecting with you, will you remain in the session? Or obviously the answer is no. Similarly, the patient has come to you with a certain set of questions, and as long as your answers don't connect to him, you know what is going to happen. You guessed it. So there are ways of connecting with the patients, ways of answering the full tosses with the patient through on us, but we'll keep this to some other day, right? And so for people who are saying, according to me, there's nothing like a fixed charges in any industry. Let me tell you, if you go by flight, the same airline, the same flight will charge you different in a peak season, and they will charge you different in a holiday, in a non-peak season. If you go in a hotel, the charges are different. If you go in the same hotel, the happy hour charges are different and the regular charges are different. If you are buying a shirt, and if you buy it from Amazon, you will see there are different charges, and in Diwali, the same shirt is having a different charge, which means that there is nothing like fixed charge in any industry. If you go to a builder, he's selling flats. He will sell the flats, the same flat at a different rate today and after 6 months. Which means that there is nothing like fixed charge. Every case is different. So if I'm doing a 3-to-3 cutting, the demand of my patient is different. The aesthetic demand is patient. The bite of my patient is different. The amount of time I have involved in interacting with the patient is different. His gag reflex is different. His appointment times are special. He wants on a Sunday. Based on that, I think every doctor has the right to charge differently to every patient because our treatment plans are customized. Are you keeping free fixed crowns which you're fitting in the patient, or you're customizing for every patient? Just answer that. Are you taking a customized shade? Are you taking customized impressions for everyone? Or you're selling like shoes. They're already made and you try to put your leg in. So then how can the treatment charge be same for every patient? So you just think over this and let me know, especially those who have answered fixed, if you agree to what I'm saying. If you don't agree also, I respect what you want to do in your practice, but this is what I want to give away to my fellow people, that it's absolutely fine to charge differently to different people. Some of them carry a guilt feeling. Absolutely, there should not be any guilt feeling when it comes to thinking about all these things. Thank you, Dr. Sumit, for your feedback. So I think, so yes, Dr. Raghuram, whatever it is right now available, you please watch it. And at a later date, definitely whatever more inputs, and nothing is complete, sir. These discussions will keep going on. Learning is a lifelong process, but whatever I can give from my end free of cost, whenever I have time, I'm trying to do my best. I hope it's adding value to your practice and your knowledge. With this, I would like to sign off, and I would look forward to reading your feedback on today's session in our today's inner circle. So once again, thank you all of you for attending, and I hope I did justice to the time you have put in today. Thank you so much.